In this second video on liver gallbladder pathology, you're going to look kind of at the progression of a lot of liver disease. Kind of with chronic liver disease, there's sort of a very common end stage for the liver, and that'll be liver failure or cirrhosis. And then we'll talk about jaundice and how to recognize that and what some of the causes of jaundice are. Now, the liver, as we've talked about, has a very strong regenerative repair potential. So a healthy liver is able to really restore balance in the majority of cases. And it's really remarkable to see, for example, with heavy drinkers, how much they can drink before there's any evidence whatsoever of any liver injury. So there's constant self-repair mechanisms. Again, acute inflammation is the way the body often uses to self-repair. But if those mechanisms fail, we start to see the development, usually over time, of liver disease. So we can start with a healthy liver. Again, if there's any injury, we have self-repair, bringing you back to the healthy state. But we start over time, if that insult on the liver, let's say it's alcohol or a virus or an autoimmune disease or whatever it might be, over time we might start to see the detox pathways fail, the carbohydrate handling like glycogen storage fail, and then we might see fat accumulation. So steatosis is often the first sign of liver injury, and that's where the hepatocytes, liver cells, become filled with fat, triglycerides. And so that's fatty accumulation. This is still, at this stage, we consider this reversible, so it could go back to a healthy liver. Unfortunately, if the liver can't heal from that, it progresses on to hepatitis, and that's liver inflammation. There's a lot of causes of this, so we'll go through some of the most common types of hepatitis. So that's not just one disease. It usually begins with an acute hepatitis. Again, that's if it is able to heal from that, it'll go back up to healthy liver. But if that mechanism fails, then we progress into chronic hepatitis. Now, some liver diseases we actually never really go through, or at least don't experience any overt acute phase. It just progresses slowly into the chronic. That can happen often with hepatitis C infection, for example. With chronic inflammation, we get the hallmark fibrosis, the collagen being laid down. Scar tissue begins to replace healthy liver tissue, and that over time can lead to liver cirrhosis. Now, cirrhosis typically progresses into end-stage liver disease, so this is basically when the patients with cirrhosis decompensate. This is at this point irreversible, so no amount of healing is going to bring that back, unfortunately. And the only treatments we have at this point really are kind of palliative care. There's things that can be done to decrease portal hypertension, like shunting the portal vein around the liver to the vena cava, etc., surgically. But this requires liver transplantation usually. The end-stage liver disease is reserved for liver cirrhosis patients. It's possible with an acute, severe insult, a person can go right into liver failure without going through the years of, scar tissue buildup and so forth that we see in cirrhosis. And that's when the liver has lost over 90% of its function. And that can happen from a variety of issues. We'll talk about those, like drug injury, like the Tylenol injury, for example, toxins, poisons, anything like that. But also infectious processes can do that too. And that can result in acute or chronic liver injury. But that's liver failure. And this requires immediate medical interventions. And I'll talk about some of the signs and symptoms of liver failure here in just a minute. But that can be fatal within weeks to months. And then with the chronic inflammatory process and chronic liver failure, liver cancer is a possible outcome as well. Now, most liver cancers are secondary, meaning they come from other sites, not the liver. So colon cancer is a common site that metastasizes prostate and so forth to the liver. But the primary liver cancers are what I'm talking about here, and that some of these cases of end-stage liver disease or liver failure can progress into primary liver cancer, and that is once we see patients with liver cancer, the prognosis is often very, very poor. That's often sort of the last stage we see in a lot of cancers. Once they've spread to the liver, we don't see a lot of, unfortunately, reversal from that. Again, when I say those kinds of things, there are always outliers, and so I don't want to sound overly negative on that, but this is just to kind of kind of tell us about what the typical statistics are and kind of what we're working with. Now, with liver failure, there's a lot of different potential signs and symptoms. And so these would be all potential red flags that would then require that person to get greater workup. But usually this person has been ill for many years. They already have medical care and they've been kind of monitored. But jaundice is classic for any acute liver injury or chronic. But that said, we often associate liver disease with jaundice, but the majority of these liver diseases present maybe with a mild jaundice at some point, and then the jaundice resolves. And so jaundice is not a good indicator of liver disease in general. We can also have acute liver injury like hepatitis A. We get very severe jaundice, and the liver completely heals in the majority of people, and there's no issues. Versus hepatitis C, which is the one that's sort of insidiously over years creates fibrosis, and there's a much higher rate of liver cirrhosis, actually in up to 50% of people with hep C, chronic hep C infection, and liver cancer. They almost never get jaundice. So jaundice is not a great tool for that. Ascites, I mentioned, this might indicate the decreased albumin, increased portal pressure. Fetor hepaticus, this is more of the end stage. These are all, again, liver failure kind of signs and symptoms. This is liver breath, and that's where the breath smells like ammonia, and that's from all these volatile waste products that are not being processed through the liver. Low albumin, low blood sugar, bacteremia. Now remember, Kupffer cells are the immune cells in the liver. They're filtering all of the bacteria that might come in from the gut via the portal vein. So the gut wall, even in health, is not completely impermeable to gut bacteria. And so Kupffer cells will filter that from the portal blood. Well, in liver failure, those Kupffer cells fail, and now the bacteria are getting into the bloodstream. Plasma estrogen will increase because of the poor detox mechanisms, and that'll cause a lot of different things like red palms, palmar erythema, what we call spider hemangiomas, these little red blood blisters that look like have little tentacles coming out of them on the surface of the skin. Testicular atrophy, that's in males from high estrogen, low testosterone, and then balding, and then gynecomastia, male breast development. Different bleeding disorders from the low clotting proteins, and then what's called hepatorenal syndrome, which is renal failure that results from acute liver failure. And that's maybe because of intense renal vasoconstriction. So your kidneys fail as well as your liver in the advanced liver disease. And then hepatic encephalopathy, this is accumulation of ammonia. Remember, one of the jobs of the liver is to handle all that ammonia from amino acids, either put it onto urea or transaminate it. The ammonia will accumulate in hepatic failure. And that can be toxic to the brain, causes a bunch of different neurological symptoms, classically rigidity, hyperreflexia in seizures. And one of the kind of characteristic signs is asterixis. Again, you might want to go online and look at videos of asterixis so you know what that looks like. But that's sort of a rapid extension flexion motion of the hands, of the head and the hands. So they kind of flap them back and forth, especially when they're trying to hold a fork or something. And the hepatic encephalopathy might progress into coma. We often see this for patients who, before death, as their organs are shutting down, we might see some degree of asterixis and hepatic encephalopathy. So those are all the more alarming signs of hepatic failure. And again, this is going to be either from an acute liver injury, but more typically from more chronic liver disease that's progressed into cirrhosis and end-stage liver disease. So let me say a few words here about jaundice or icterus. This is yellow skin and sclera from increased serum bilirubin. So the bilirubin is not leaving the liver properly or not being processed by the liver properly. Again, as I just mentioned, many people with severe liver disease aren't jaundice, and liver disease isn't the only cause of jaundice. So you can have problems of your red cells being hemolyzed too quickly, for example, in sickle cell anemia, and that can result in jaundice. So that's why we have to do a full differential to kind of figure out where the jaundice is coming from with patients. Many of the causes are non-serious, non-life-threatening, but others can be potentially fatal. So again, proper workup is important. Jaundice in newborns, just to start with that, can be physiologic, and that occurs in the first week in about half of newborns, and it's benign. and that's occurring within a day or 2 to 3 days after birth. And it's due to the enzyme in the liver called glucuronyltransferase that's supposed to attach glucuronic acid, the sugar, onto bilirubin to make it direct or conjugated, and then that is able to go into the bile and is excreted. Without that enzyme, we get an accumulation of indirect or unconjugated bilirubin in the body, which is much more difficult to eliminate. And this is just due to the fact that newborns have very either no or very little activity of that enzyme at birth. Remember, this is one of your 6 phase 2 detox enzymes. Bilirubin usually is less than 5 milligrams per deciliter a day at the beginning, and it peaks maybe to just under 15, and it usually then resolves. So this is benign. So it should be resolving after that first week. Pathologic bilirubin is present right at birth, and this can cause kernicterus, which is, if you go over here, kernicterus, this is an accumulation of bilirubin in the gray matter of the central nervous system. So kind of like the ammonia, this is a different mechanism that can damage the brain, causing irreversible brain damage. And newborns have a very poor blood-brain barrier, and so they're much more susceptible to this. There's a lot of reasons for pathologic jaundice in newborns. There can be genetic, so there can be inherited hyperbilirubinemias. The bile duct system maybe didn't form properly embryologically. That would be called biliary atresia, so all the bile backs up. Or probably most common would be erythroblastosis fetalis. This is the reaction to Rh antigens. So remember, on your blood groups, we have our major blood groups, A, B, O. And what these are on your red cells, A is there's an A antigen, B, there's a B antigen, O is lack of A or B antigens. But then there's another antigen, and that is the Rh, rhesus antigen. If you're Rh positive, that means your red cells have it. If you're Rh negative, that means they don't. Well, if a Rh negative mother has a baby with an Rh positive father, and the baby actually turns out with it, well, it doesn't matter if the babies are, if the baby in the first baby is Rh positive or negative. What happens is, if that baby is Rh positive in that first pregnancy, the mother will actually create antibodies. So there's some diffusion across the placenta, will create IgG antibodies to this Rh antigen. And for the first pregnancy, that usually is not a problem. But the second pregnancy, if the baby again is Rh positive, now the mother's IgG antibodies can actually diffuse across the placenta and will attack the red blood cells on that baby and destroy them, causing hemolysis that'll cause massive outpouring of bilirubin, and that's going to cause the pathologic jaundice. So that's the erythroblastosis fetalis, and this is why mothers who are Rh negative with Rh positive fathers will receive RhoGAM injections. RhoGAM is an antibody against this antibody. So it's an antibody against an antibody, and so that'll tie up the mother's anti-Rh IgE antibodies. It can also be treated, so that's going to be, the RhoGAM is going to be more preventative. Can also be for treatment right at the time of delivery. But usually if jaundice develops, there's different things that can be done. One of them is to expose the baby to blue-green light. That's called phototherapy. And this causes, the light is absorbed in the capillaries on the surface of the skin, and it causes the structure of the bilirubin to break down. It's able to absorb that light, it vibrates it, breaks it apart, and it allows the baby to process that more quickly. So that's jaundice in newborns. In terms of general presentation of jaundice, again, yellow sclera is going to be the most typical. The bilirubin is absorbed by the elastin whenever the plasma concentrations are over 3 milligrams per deciliter. So if you see it in the sclera, that means you got bilirubin at least that high, and it's being absorbed in the elastin of the sclera. Yellow skin can also happen, but that's going to happen at a much higher level than the 3 milligrams per deciliter. Urine usually will be very dark from the bilirubin in the urine, and it actually gets oxidized in the urobilinogen. That's what we see in the urine. Feces may be more pale, and that's because of the lack of bile coming out if there's any obstruction. So that would be for obstructive jaundice. and the feces will be pale. There might be steatorrhea. Again, pruritus is something that we often see with systemic accumulation of bilirubin. The bile salts form in the skin together with the bilirubin, and that creates itching. And then serum cholesterol can also be severely elevated from any cholestasis. So these last three are going to be more typical of cholestasis patterns. And then cholesterol might even deposit in the skin, forming xanthomas. Those are little collections of cholesterol. Again, you might want to Google the pictures of those. They can accumulate around the eyelids, and the hands, and so forth. That's from very, very severely elevated cholesterol. Again, that would be more from obstructive jaundice. And then we talk about the kernicterus. So what causes jaundice? Well, there can be several different causes. One is before the liver, so we call those prehepatic causes. And that's from defects in red blood cells, either intrinsic to the red cell or something like a drug or something that destroys the red cells. Or in the case of erythroblastosis fetalis, the mom's antibodies destroy it. The most severe cause is hemolytic anemia. There we get increased unconjugated bilirubin, and the urine will be light in that case because it's not very water soluble, so it's not going to get out of the body. And we might actually get pigment stones. This is accumulation of bilirubin in the liver and the bile ducts. It's unconjugated, and that creates a type of gallstone, not very common. Most gallstones are made from cholesterol, but these would be pigment stones forming on the gallbladder. There can be intrahepatic causes, and that would be from any illness impairing the hepatocytes. And the most common would be hepatitis, cirrhosis, or fatty liver. And that would increase conjugated bilirubin, and the urine would be dark. So that would be from conjugated bilirubin. So once the bilirubin gets in the liver, even with liver injury, the liver is able to process it still and conjugate it to some degree. And that's why we get more conjugated bilirubin. There are hereditary hyperbilirubinemias. These are relatively rare, but there are several well-known syndromes, and that can cause either an increased unconjugated or conjugated bilirubin, depending on the cause. The most common, present in about 5% of the population, is called Gilbert's or Gilbert syndrome, and that is increase in indirect bilirubin because of a lack of that glucuronyltransferase enzyme genetically. We think this is benign. There doesn't seem to be any increased cardiovascular or other risks in these patients. But that's something when I have patients come back, we do their labs, their bilirubin comes up, they have no other symptoms. That's something we consider as maybe they have Gilbert's. And it usually runs in the family. So maybe they say, yeah, my dad had high bilirubin as well. And then there are post-hepatic causes, and that results from a blockage. This would be obstructive jaundice, creating cholestasis. And so here we're going to see again the conjugated bilirubin increase with dark urine, light stools again because the bile is not coming out. We might actually see steatorrhea, which is the lack of bile salts. We get poor fat absorption. Gallstones are the most common cause, but you can get strictures, maybe from previous bile duct surgery, something called congenital biliary atresia, where we just don't form the bile duct in embryologic development. That would be found very early in life. And then tumors can block the bile ducts. But again, gallstones are the most common there. So if you see a patient with jaundice, again, if you're not a PCP, they need to be referred. But typically what's done is to obtain a liver function test to determine, first of all, if it's high bilirubin. So we're going to look at the total bilirubin, but then we're going to look at the amount of direct bilirubin, the conjugated, which is, if that's going to be elevated, that's always pathological. And then the amount of indirect or unconjugated bilirubin, and that can be either pathological or not pathological or physiologic, like we just talked about. And then we're going to do further imaging and testing, ultrasound, maybe CT, maybe some of the contrast agents to kind of narrow down the cause there. And the treatment would be really aimed at addressing the underlying cause. So that's an overview of jaundice and how to think about it and how to approach it. I just want to include here the final common end stage of a variety of chronic liver diseases, and that is liver cirrhosis. And we get in liver cirrhosis a progressive, it's irreversible past a certain point, incurable scarring that destroys the liver architecture. And so we get extensive fibrosis, And if you look inside the liver, you see these webs of interconnecting scar tissue. It divides the liver into little nodules. They're separated by dense fibrous tissue, and the liver becomes tense and hard. And then you see pockets of liver trying to regenerate. That's called nodular regeneration. The hepatocytes react to the injury. They actually start to proliferate. But the normal kind of structure, architecture of the liver breaks down. So it doesn't look like a normal liver anymore. The blood passes through these little nodules inefficiently, so they have very poor ability to do all the different functions of the liver. And it's prone to liver failure. Cirrhosis is among the top 10 causes of death in the Western Hemisphere. Now, typically, it's been the result of chronic alcoholism or chronic viral infections like hepatitis C. We're now seeing another player, unfortunately, and that is non-alcoholic fatty liver disease associated with type 2 diabetes can progress over time to liver cirrhosis. And in fact, we're kind of expecting an epidemic of that in the next maybe 20 years or so, because a lot of people now, there's about a third of, interestingly, the American population currently has been diagnosed with some degree of non-alcoholic fatty liver disease. And this is thought to be due to primarily a Western type diet with a sedentary lifestyle. So we might see a huge explosion of liver cirrhosis in the coming decades. The important thing with the liver, again, is it can lose a huge amount of cells, up to 2/3 of them, and still regenerate. But in the case of cirrhosis, all the scar tissue really prevents it from regenerating. That's why we get these nodular regeneration, but not a full reorganization of the liver. So lots of causes. Any sort of chronic liver disease, specifically usually chronic hepatitis, and that could be from viral hepatitis, so viral infections. Hep C is the most common. Hep B, you can actually develop chronic hepatitis from that in some people. Chronic alcoholism. So those have been the most two common. But now we're seeing NAFLD, the non-alcoholic fatty liver disease, progress into non-alcoholic steatohepatitis, which is the inflammation, and then that goes on to cirrhosis. The iron storage diseases, again, these are genetic. Hemochromatosis, we over-accumulate iron in the body, especially the liver. And Wilson disease, you accumulate too much copper. Alpha-1 antitrypsin, I mentioned already. Again, these would be more rare genetic. Autoimmune hepatitis, this is an unexplained sort of immune attack on the liver. We're not sure what triggers it, but people usually have another type of autoimmune disease like lupus and so forth. Any sort of chronic biliary obstruction. Primary sclerosing cholangitis can result in biliary obstruction. Heart failure with portal congestion, so all the blood backs up in the venous tree, congests the liver. That can actually over time lead to liver failure. Sarcoidosis, accumulation of sarcoid, unknown connective tissue disease that accumulates collagen in different organs. And then many cases can also be cryptogenic. We're not sure why, but a person progresses into cirrhosis. But probably these top three are the most prevalent in terms of causes for liver cirrhosis. We can classify it anatomically by whether or not it affects the called portal cirrhosis, so around the portal veins and around the portal triads. And this causes more of a diffuse liver injury. And this is the most common from chronic viral hepatitis or alcoholism. But you can also have chronic disease in the biliary tree, and that causes biliary cirrhosis. And this is more typically autoimmune or chronic inflammatory nature. Or we can classify it based on cause. So you might, if patients with cirrhosis, if you're working with them, they might come with their pathology reports, and that might be relevant there. The complications would be liver failure, like we just talked about, and I won't review all those signs and symptoms. But again, ascites is a big one here. You see the big ascites belly, all fluid filled from the increased portal tension, hypertension, as well as low albumin. And then portal hypertension can cause the esophageal varices, and that can result in hemorrhage, vomiting of coffee ground, looking oxidized blood, can cause internal hemorrhoids, and then further worsen the ascites. Also, the blood all just sort of stops flowing adequately. The pressure builds up in the portal system, and there's much more risk of portal vein thrombosis. You get blood clots in the portal vein. And then hepatocellular carcinoma, this is one of the primary liver cancers. And usually we have many different tumors that pop up throughout the liver. So those are the three primary complications: liver failure, portal hypertension, hepatocellular carcinoma of cirrhosis. The treatment really is supportive. So there's, for esophageal varices, there's what's called sclerotherapy, or banding of the bleeding vessel. Sclerotherapy is injecting an agent which cauterizes the inside of the vessel. Ascites, you can do what's called paracentesis, put a needle in there and you basically draw it out, but of course it's going to come back. Treatment for hepatic encephalopathy would be using lactulose, neomycin. These are typical agents used for that. There are liver shunts that can shunt the blood from the portal vein around the liver to the vena cava. That decreases the pressure in the portal system. Obviously, you would no longer be properly detoxing the blood that comes in from the portal system, but that would be a temporary measure. But in the end, most patients, if they survive and they qualify for it, are put on the list and receive a liver transplant. That's really the only treatment for the end-stage cirrhosis that we have currently. So that's a summary of some of the kind of basic liver conditions, the progression of liver disease, a bit about jaundice, and a bit here about liver cirrhosis. And now we'll start delving into individual liver conditions in the next video.